Okay, don't forget that you have your medication quiz that's due by Saturday night at 11:59. You have 3 chances to get the score you need, and you should be able to see your scores. Okay, if you have any questions, just let me know. This is your last week of lecture. So I'm sure you're all very excited. So how do you feel about accidents, disaster, and bioterrorism? It can be exciting, but can also be very, very scary, especially we've had a lot of the tornadoes that have gone through. And so what we're going to do is talk about how we're going to triage. Now, this is through the ENA, the Emergency Nursing Association. So it's going to be a little bit different than those of you who do work pre-hospital. But just remember that you'll have both of those skills as you are becoming professionals. And a lot of you will be working in the emergency department. So you'll get to make the transformation between both, from student now to a practitioner or a provider. Yes. All right, somebody's going to come up and help me fix this because I am very bad at any of this stuff.
Hello, hello.
Do you have a mic on?
This one's off, that one's on, but that's with the system. And I've turned it all the way down to 10.
Okay. Maybe if you turn your volume down up there,
Okay, how?
maybe that would work. I don't know. I don't know why they called me up here, really. So.
Because this is the mouse, and this controls that. I don't know.
Is this better?
Sounds pretty good up here.
But again,
Check, check.
Maybe it's that?
because then it was really.
Okay. I don't know. This is
It's all. Echo still?
well, maybe we could just. It's better than what it was.
Okay. What'd you do, Derek? Okay, this day is going to be a total challenge, just so you know. So why do people come to the emergency department? Good. Yeah, but this is not working now. I have to go slide by slide. Why do people come to the ED? Oh, and by the way, why do we call it emergency department as opposed to the ER? Right. Back in the day, you didn't have different individual rooms. You had one big area that was divided by curtains and beds. So that's why it was the emergency room. Now we have a lot of different, or in the department, we've got many, many rooms. So that's why we call it the ED, emergency department, as opposed to emergency room. Okay. All right, so does everybody that comes through our doors, do they have a life-threatening entity? No. Why do they come in? What's that? Doctors know? Sutures out, which seems kind of silly. They're what? Okay. Well, they could, because they might have had a concussion and then they couldn't get into their doctor. The emergency department is open 24/7, but what you also have to remember is if you would go into the emergency department, are they going to ask you for your insurance information? No, not until after you've been triaged. If they would do that, that is a huge fine. So you have to be triaged first before they ask any of that information. So there are individuals who will come to the emergency department because they know that they don't have to pay. Whereas even if you go to a physician's office, you're going to pay a copay. And some individuals don't have that. So that's why they may come to the ED as opposed to going to a physician's office. Plus again, we're open 24/7. When do you think most pediatric patients come into the ED? After 5, because that's when their doctor's office closes. You didn't fix it, Derek. Okay, we'll try that. That's even worse. Nope, this one's off. This one's on, this one's off. This is the one I normally use, but this goes with the system. Okay, so they might go to the ED because it is life-threatening. They're an aging population, they want to be seen right away. They have a lot more health issues. People are being discharged earlier than they had been in the past. So that means that all of their problems may not have been addressed. And so they are coming back as a repeat offender, so to speak. In addition to the ED, we also have CDU. Does anybody know what that is? Clinical Decision Unit. What happens there? Right. So they may have tests that they're waiting on results for those. They may be there in the CDU waiting for a room. Or they may be people who come in as 23-hour observation patients. So they need to be monitored, but they are not a full admit. But they'll still have nursing staff and physicians who can come in and see them. Okay. We can also have patients that have acute mental crises. And we want to help them as much as we can, but that's also a problem. Why is that? We don't have psych at St. Francis yet. They're still going to build that institution North Allen Road, but we don't have it right now. So they will stay in the emergency department, not necessarily in CDU, but in Pod 1 until they can be placed, which could be in another city. If they don't have health insurance, they definitely. So there's a lot of different reasons why people come to the emergency department. The ENA, which is the Emergency Nursing Association, And I really highly encourage all of you to join this that's affiliated with what you're interested in. So there's CCRN for ICU, surgical groups as well for nurses, as well as ENA for nurses. They develop the standards of care as well as certification processes. So any of you who are going into the emergency department within the first year, you'll take a course, pediatric course, your certification, and also the TNCC, which is trauma nurse course. ENA is actually international. So certification you get will go throughout that you traveling throughout the United States. If you work in Illinois though, and you want to be a trauma nurse, that is a TNS, trauma nurse specialist. That is only IDPH, Department of Public Health, recognized it. And it's the hardest test I've ever taken. 100 times stronger or harder than boards, but they prepare you for it. There's like an 8 to 10 week course that you go week and practices as the written test. And if you don't keep up your contact hours, then you have to go through that all over. So you don't want to do that either. You need to be able to recognize anything that's going to kill them first. So you do a series of assessments, which you always do A, B, C, unless it's, and we're always go to still assessing their ABCs, their airway, their breathing, the ventilation. We'll actually do all of the different letters of the alphabet as we're doing. Get very, very quick as you become more and more confident. We need to initiate interventions to reverse or prevent any crisis, and that's why RED and many are all under down. Individuals with the ability to come have to have a badge to get into the department. Our visitor, they look like cards that are cells. RED is also set up for disasters, that if we have patients more than what we can put in the pods, we actually have areas that have suction and oxygen that are outside the pods, and then there's out of them. So they can be on a gurney, but still get the care, not the critical care that some of them get in the. And we are, that's actually in RED, but different, have different setups. So what does triage mean? It means to sort, French. So with our triage, how long should it take you to determine whether a patient less? And we have an adult triage as well as a ped. So if it starts with that algorithm, that's for adults. If it's the jump start, that's for kids. They go down the tubes a lot. That's why we also have everybody is being triaged if it's a disaster of some type, so green is walking wounded, actually help. After green, that very, they may have vitals that are borderline. They can't walk. Cognizant. That's an MP. Next one is red. That is a full, actively cold. That person, black, they're dead. Some systems, they have blue. Not in our system. So our triage system will categorize our patients, use the ESI, which is the severity index, and that goes from 1 to 5. Most critical to you? 1. Number 1 always gets, they need the majority of the resources, which could be tests, it could be people at the bedside who are taking care of them, so their severity is quite high. And that incorporates the concepts of illness severity and resource to determine who is treated first. Do it, the better you'll get. Also have friends to help you with that as well. The ESI is supported not only by ENA, the Emergency Nursing Association, but also the American College of Emergency Physicians. So this is an example of our 5-tier ESI. 1 is unstable, probably going to need to be coded. 2 is threatened, so they're a little bit healthier, but not, they could actually go to an ESI 1 very, very quickly. Your ESI 1s are going to be in the trauma rooms base. ESI 3 is stable, but if they're older, if they have a hip fracture or a pelvic fracture, we know that that can make them very critical, not only because of their age, but how much blood those support. How much blood circulates through 1.5 liters. What about your femurs? 1.5 liters. So if you broke both femurs and your pelvis, you can potentially lose up to 4.5 liters of blood. And how much circulating blood do we have in our body? About 7 liters. So they would be definitely somebody who is in danger of resting and dying. ESI 4, they're not as critically ill, but they're still using a lot of resources. And then ESI 5 could be refill of prescriptions, it could be a pregnancy check, removal of sutures, removal of staples. So those are just some of the examples, and we'll do more of those as we go through. So what we're going to also look at is how much of a threat to life or organs. So if it's an ESI 1, it's obvious. They're bleeding out. They're in full arrest. They are in a lethal dysrhythmia. ESI 2 is likely but not always obvious. 3 is unlikely but possible, and ESI 4 and 5 are not life-threatening. So those are going to be the patients that are going to be there for a while. Once they have a change in their status, such as in their airway, breathing, or circulation, we can move them up in severity. Their ESI also is determined by how soon they need to be seen by a provider. Is it immediately? Is it within 10 minutes? If it's immediately, that's an ESI 1. They're probably actively being coded as they're coming in from emergency services. If they're an ESI 2, they're still pretty critical. They need to be seen within 10 minutes. ESI 3, up to an hour, and ESI 4 and 5 could be delayed by hours because they are not critically ill. If it's a slow emergency department, then they might be seen a lot quicker. There's a lot of individuals who will go to smaller hospitals to their emergency department because they think that they'll get treatment faster, which could possibly be. But it just depends on if they're getting overrun by people as well. So the next thing we're going to look at is the resources that they're going to be using. Are they going to be using a lot of meds, a lot of IVs, a lot of people who have to be at the bedside, a lot of tests that have to be done quickly? Are they going to go to surgery quickly? How many staff are at the bedside, and how often are they there? Do they ever leave? So like an MI, a fresh MI that's coming in, what do you think their ESI is? I put them at a 1 because you're going to have a minimum of 2 to 3 people with that person at all times. Okay? You never leave. And in case they would go into a cardiac arrest, then we have to immobilize the team. So that would even be more resources. 2, they're going to need a lot more diagnostic studies than the 3, 4, and 5. with frequent consultation and more than one type of consultation, and continuous monitoring. If they're an ESI 3, they can still use high resource intensity. They're going to use a lot of diagnostics such as labs, x-rays, brief observation, and they may get boluses depending on what their problem is. ESI 4 is low resource intensity. So 1 or 2 tests, simple procedures like sutures or stapling, they're in and out. It might be an ear infection. So once that child gets their antibiotics, then they can be on their way. ESI 5 is low resource intensity. That's examination only. That could be somebody who's coming in with poison ivy just because they don't know what to do with it. Doesn't mean that it's life-threatening, but unless they have an allergic reaction, then we would move them up the severity. So some examples, if they're an ESI 1, cardiac arrest, they need to be intubated or they are intubated. It could be a drug overdose. They're suffering from bradypnea, severe respiratory distress, and you know that they are going to need a lot of resources as well as caretakers. ESI 2 is chest pain probably resulting from ischemia, multiple trauma, unless they're responsive. 3 is abdominal or gynecological disorders, unless in severe distress. It could be a hip fracture in an older patient, again, because of the potential for bleeding. And they're probably going to have surgery based on the fragility of their bone at an older age. ESI 4, they have closed extremity trauma, simple lacerations or cystitis. And ESI 5, people do actually come to the emergency department with cold symptoms. They could come in with a sunburn, recheck a wound, prescription refill, things like that. Does that make sense as far as ESIs? Could you be able to differentiate between? So after we do an initial focus assessment to determine what their actual problems are, and what is one thing that you have learned about patients? They don't always tell you the truth. So you have to be very inquisitive and ask all kinds of questions. Look for the elephant in the room. What's the most obvious? What are they not telling you? Why are they here? Why are they so demanding? Why is their family so demanding? So these are things that you need to consider when you're trying to figure out how you're going to care for your patients. You need to have a systematic approach to your assessment to identify any potential threats that they may have that they're not telling you that's going on. They will not necessarily tell you about a previous health history if they're coming in with a problem that they feel is unrelated to their health history. So you have to be inquisitive, ask questions, spend time with them, treat the life-threatening entities first, but know that there may be something else, some underlying disease that they have going on that you need to address. We're going to do primary and secondary assessments. And I will hit this often because a lot of people don't understand the difference between your primary and your secondary assessments. So what's the first assessment that you're going to do when you come in to see your patient in the emergency department? Or that? What's that? Okay, and how are you going to observe that? Across the room. So your first assessment is across the room. What are they doing? Are they reading a book? Are they watching a movie? Or are they playing with their eyes closed and the tongue hanging out? Then we would decide we probably have to interact very, very quickly. So that's your across the room. Your primary then are your ABCs. You're going to do A, B, C, D, E, F, G. Do all of those. You're going to have help. That's your primary survey. We're going to go through all of those. What's H? That is the beginning of your secondary survey. What is it, Ethan? That? It's your history and your head to toe. So what are some forms of history that we can take? Could be from the patient, could be from their charts. It could be family members. Or you could, if there's somebody that, if they were picked up by an ambulance, then they could also give you some part of the help. And then you're going to do the hands-on head-to-toe assessment. And we will talk about it a little bit, but for peds, we're still flipping kids over if you want to look at their posterior surfaces. But for adults, we have to weigh in. Were they a trauma? Is it going to cause more problems if we log roll them to their side? Could we cause more damage to their spine? So we want to make sure that their spinal cord is intact. We'll talk about that, the right way and the non-right way to do that. And then we're going to take care of our patients who do not need to have that head to toe. The non-traumatic patients, we're just going to do a primary survey followed by a focused assessment. What is the reason why they came into the hospital in the first place? So that's how we differentiate between the two. So we're going to go through all of these, A, B, C, D, E, F, G, H. A is alertness and airway. Is their airway open? Do they have cervical spine stabilization? What is an example of C-spine stabilization? Collar, a C collar. What's that little diamond that's in front of the C collar? Want to see the trachea. Is it midline or is it deviated? If it's deviated, what could that be? What could that be caused by? Tension pneumothorax, cardiac tamponade, which are both life-threatening in themselves. They need to be treated immediately. What would be a form of immobility? Spine board and spider straps. What kind of things can we use besides the C collar to help stabilize or immobilize a head and neck? Pine, foam. Okay, what did we used to use? We used to use sandbags. Why is that bad? They could shift and snap your neck. So we have a patient on a spine board, spider strap on. We're going to start at the feet and go head. We're going to do the head and go head to feet. I hear head. Head first. Feet first. Because what if they have if they have their head and neck, have a seizure, snap their neck. Start at feet first. And use blocks, foam blocks, not sandbags. And what else do you need besides people to put them on the spiders? Need people to help carry them and get them big. And you need one other person for that. That's your Simon leader. That's the one who bosses people around and says, count of three, we're going to lift. So that's an old Boy Scout term. Simon leader. But in a trauma, take charge, that's when you need somebody, Simon leader, to say this is what. And people will listen. Does that mean that you're gonna have the same leader time and time again? Not necessarily. It's got to be the strong. All right. So we're gonna check their alertness. How can we check their alert? By name. They look at you. We want to make sure their airway's open. How can you assess cognition and if their airway's patent or open? Ask them to open up their mouth. They follow commands and that could be anything. You need to make sure you get whatever is out. What must you as a provider never do when you're checking airway? Don't stick your fingers inside their mouth while you stumpy. They have a seizure and they chomp down on your finger, not going to have that finger anymore. And remember, the human mouth is one of the dirtiest places in the earth. So anybody that gets a human bite that breaks the skin, they can get ravenous infection. So we check their airway. We're going to look at their trachea, see if it's gated, see if it's in midline. We're going to look at their breathing. Fast. Is it shallow? Is it seesaw? All of those things. Or is it some other breathing pattern that we know is not viable with life? You're going to check their circulation. You're going to check your peripherals with your centrals. You're going to look at any type of bleed that you can see. And if they look really pale and they've got a really bleeding all over the place, what kind of hypovolemia is that? Absolute. You don't learn anything before you leave. You have to know relative and absolute. Yeah, that is my goal in life. Make sure you know that. So what are we going to do if they're bleeding out? Apply pressure. Give fluids. You're going to give a lot of fluids. How are you going to get them? Besides rapidly. Warm. You can drop their body temperature really, really quickly, and they're already stressed from the trauma. And determine, do they need fluids like lactated ringers or saline? They need blood products. And if we're going to get blood, what are we going to give if we don't know what their type and process? O negative. You're also going to look at cap refill. And we are adults. What is normal adult cap refill? Less than 3 seconds. Then we're going to check disability. What's disability? Does that mean can they walk? No, that's a neuro component. So do they recognize you? Have food? Hurt? Are they responsive to verbal stimulation? Are they responsive to pain? Are they unresponsive? We're going to look at their pupil. They react. Are they pinpoint? What could be for diagnosing their pinpoint? What does that tell you? Opioids, it's a really bright light. Cause the pupils. What if they're dilated? Head? Could be a head injury, yeah, or in a very dark room. Or it could be drugs. Then we're going to expose them, and we're going to warm them up. So if they've got any clothing that's impeding their resuscitation, we're going to get that off. And that's how we're going to see where the injuries are. If it's a knifing or a gunshot wound, what are you going to do with their clothing? You're going to preserve it because it's going to have to, it's considered to be part of a crime scene. So don't cut through clothing if there is any if there's any gunshot wounds. And what are you never going to do? Stuck in a body. Right, you stabilize it. Because it might be stopping a killer. And then we're going to warm them up. Warm blankets, warm fluids. thing that we can do to make them not so stressful. How many of you been in the trauma room? What's the temperature? Like 100, I think. Walking in it. And that's because we don't want our patients to be. That does not lead for a good outcome. We're going to facilitate adjuncts, which means we're going to get the family in if they need to be. How do you feel about family and resuscitation? They want to be there and they are not. I know there's a lot of people that don't there because they get in the way. Yeah, they shouldn't be there. Sometimes what would be an advantage family in the resuscitation would be a reason for not having them there. Correct. That can happen, but what must happen if we're going to have people, family members? Have to have somebody assigned to them. Have to have somebody who can. Daughter and the husband got trapped in the room. And he got trapped in the corner house before. Daughter said, "How brutal CPR is, I don't." About this big. And then about after 5 minutes, like, let's try. And I was proud of the resident. Had 5. That was left. So, minute that your brain. Then that it was decided that they would. If family is there, have to be able to. And every situation is going to be better, but they can be good and bad, and that way family can know things have been done. And we explain to them what we're not doing things. The resuscitation adjuncts, that's your LMNOP. What do you think that is? Labs, if you don't. You get your when you start IVs, which you get at least gauge, get labs at that time. M, monitor, see what their heart's doing. N, nasogastric or gastric tube. P, we want to treat their pain. How are we going to treat their pain? Pharmacological and non-pharmacological. And then everything we do, we will assess. That's your key. Assess. So that's all primary. Then we go into your secondary, the history. MIBT, if it's pre-hospital, it's a mechanism of pain. Vitals taken, treatment. Hospital, it's missed, which is basic MIST, basically this hospital. And again, you can talk to family if the patient is not cognizant, find out what kind of family history they have, as well as person. If you have a younger person who is brought in kind of accident, you could ask parents, but what's a really other and why this accident happened in the first. Friends are there, siblings are there. Siblings will find out a lot more information from them. Especially if the child that the adult that we brought in, not really true about his drug. Siblings will know. Friends will know. And then we're gonna do our hands-on, head-to-toe assessment. When do we take the board off? They're supposed to take it off after their seat. All right, so your primary survey focuses on airway, breathing, and circulation, your ABCs, which we talked about. It's also your disability, the facilitation of adjuncts, and the family family presence and resuscitation. Everything changes when it's uncontrolled bleed. So instead of your ABCs, of course, you're going to open your airway, make sure you're breathing, but you want to stop that bleeding, either with direct pressure or taking them to surgery. You would only apply a pressure dressing after you have stopped the bleeding. So you're going to have your hands in the groin or wherever there's bleeding. Make sure that you put dressings or something to try to stop that, plus the pressure. Are we going to take off the old saturated dressings? No, we just reinforce, because you don't want to tear off a clot that might have already started to form. So if your situation is life-threatening, relating to their ABCs, we're going to identify those during the primary survey. But just because you identify it during the survey does not mean you just go through all the letters and don't go back. Want to make sure that you are stopping the problem, getting them the help that they need as quickly as possible. If they need to go to surgery, in addition to all the blood products that we're giving. And then we can proceed to the next. So we're going to look to see, are they alert? How is their airway? Is it open? What are things that could be in there? Level of consciousness, ask them what their name is, ask them any other information to just determine if they're with you or not. Are their eyes deviating in one way or the other? Are their pupils fixed? How many of you have seen a sternal rub? Is that something that's comfortable to watch? No. Are there other forms of noxious stimuli that we could deliver without doing a sternal rub? Cordial thump is not one of them. A lot of times that's what you're going to also try to move their back. That's very painful. Some people would stick, I've seen some put needles in if they can do that. That's not really a very good way to do it, because if they've got calluses on their feet, probably going to have decreased sensation. Also, if they're diabetic, they might have decreased. That's not necessarily a good thing to do either. And again, we're going to do ABFU. Are they alert? Are they responsive to voice? Are they responsive to pain, or are they unresponsive? This is not, are they all four? It's whatever, if they're unresponsive, they're unresponsive. They can't be any of the other three. Want to look what could be obstructing their airway. Saliva, bloody secretion, vomit, laryngeal trauma, dentures, facial trauma, fractures, or anything that could be, especially if it was a motor crash. If you have a patient that has dentures and you're going to do CPR, and I'm not going to make you do mouth to mouth, but you could do mouth to mask or ambu bagging. Are you going to take those dentures out? No. Because, think about it, with the dentures in their mouth, now they have this gate. Speaking from somebody that even are ambu bagging, if you take their dentures out. Now, once it's determined that they need to be intubated, then they will be broken. We want to make sure that their airway is not compromised. If they're seizing, we want to try to keep their airway open. If it's a drowning victim, what kind of fluid did they drown in? And we'll talk about that a little bit later, because there's certain types of water that you would want to drown in, and certain ones that you would, not that you want to drown at all. Do they have anaphylaxis? Were they in contact with something that they are highly allergic to and forgot to bring their own? Do they have a foreign body obstruction? And again, if you can see it, check it out, but don't blind finger sweep. That's been out of the algorithm for many, many years. And if they're experiencing cardiopulmonary arrest, want to do CPR. So we need to open their airway. How are we going to open their airway? Head tilt, chin lift, unless, what? They have a neck injury or a spinal cord injury. How are we going to open their airway if they have fallen, if they are definitely compromised in the neck area? Going to do a modified jaw thrust. Seen those done? Have you done them? Not hard. It looks like your patient has trismus. Bring that lower jaw forward. You guys practice on each. Asking, would you do? Probably not, because your jaw not going to be able to open up. Head tilt, chin lift, you can practice on each other. If you do a head tilt, chin lift, make sure you're on the bony part, not the soft tissue. Actually cause. And once you open it up that way, you need to. What could be a way to keep their airway open in front of you? Right, you could put a towel or blanket underneath their blades. Depending on the type. Once you open their airway and limit your ability. If we don't get that airway open, they could die from hypoxia. So signs and symptoms of airway compromise, they could have sonorous respirations. They are not going to be able to speak. They could have dyspnea. What do you think about gasping agonal breaths? That's an oxymoron. If they have agonal respiration, they're not respirations. Their body trying to jumpstart them to not getting any up. So if it's agonal, that's almost as bad as nothing else. We want to open their airway, get whatever is out that could be compromising their airway, and it could be anything. Products, but it could also be they consume something that they didn't know that it had an allergen for them, and so that could actually cause the laryngeal swelling. Do they have trauma to their face or neck? That's going to compromise their air likely, and fix them and get an airway in as quickly as possible. If that would happen in the field, what might you see that patient come in with for ambulance? That louder. They could have a trach or a trach. This surgical cut that's done in the field. But they could have a tube as well. So again, we're going to open that airway with the modified, or using the jaw thrust maneuver. Don't hyperextend. Just open it up until you can see breath come in and out. Suction or remove that foreign body. We could also put in a nasopharyngeal or an oropharyngeal airway. We put a nasopharyngeal in a patient that is conscious or unconscious? Either. What about an oropharyngeal? Only unconscious. Because where it sits is right at the gag reflex. So you could cause them actually to aspirate. How do we size a nasopharyngeal? Tip of the nose to the tragus. How do we size an oropharyngeal? First, either the earlobe or the angle of the. Your book will say for an oropharyngeal airway, put it in upside down. That is not that for years. Do is go sideways because we can't. These will only keep the airway open until we can get the patient intubated. And you can actually ambu bag around them. The ET tube is for individuals who've been trained to do them. And when they put that ET tube in, pull out the stylet, are they going to inflate the cuff first and listen to breath sounds? Where are you going to listen? Stomach. You're still going to listen over the breath sound or listen over the lung. You're going to look for rise and fall of chest. But think about it. Have a patient that's becoming intubated that usually are really, it's very, very loud. So you might listen here, hear things. You listen in the stomach and you hear. So you're going to listen to breath sounds. You're going to look for rise and fall. What else are we going to do? Might use the end-tidal CO2 allometric device, but between the ambu bag and they can either be yellow, blue, or purple. All it's telling you is it's detecting an acid. So carry that in mind. Could we have intubated the esophagus, you'll get a good. Yes, why? Okay, so these devices are detecting an acid. Can't determine whether CO2 hydrochloric acid. That's why it's not the gold standard. What is the gold besides chest X-ray? Capnography. What number do we? 5 to 40. And if you've got the fancy kind, we do capnography set on inspiration or expiration. The CO2 movement. We could also do rapid sequence intubation. What is that? That's when we sedate and paralyze. It's a very short procedure, and it's only long enough to get that tube in. And incidentally, how long should it take to intubate a patient? Seconds? 3 seconds? shorter period it takes to get, get it between 10, 15 seconds. Are we going to sedate them first, or are we going to paralyze them first? Paralyze somebody before you. And if they are getting anesthesia, then that provider has to have privileges in order to give anesthesia. All is one of them. They really like it for propofol. They like propofol kids. Doesn't last very long. The second it goes in, they're out. The second they turn it. No long-term effects like with some of the others. So again, we're checking their alertness as well as maintaining their airway. We can be looking at their rise and fall of the chest. We can be looking for injuries that they might have. What is going to be our next step? What are we going to do for them? We want to make sure that C-spine is stabilized with either a C-collar, which is a stabilizer, or a CID, which is an immobilizer. Going to keep the bed or the head of the bed flat to continue to monitor their airway and their breathing. One of the adjuncts that we may do is actually to intubate them. But we want to also assess them because we know that if they've got fractured ribs, that's going to interfere with their respirations. They could also have a tension pneumothorax, which, what are you going to see with a tension pneumo? What are you going to assess? Absent breath sounds and tracheal deviation. Which side is the trachea going to deviate to? The injured side or the uninjured? We're going to look for penetrating injuries. Do they have something that's stuck in them? What if they're impaled on a fence? What are we going to do? We're not, but pre-hospital is going to cut that fence and transport them by making sure that fence part of that fence is stable in that body. And then they'll go to surgery to have it surgically removed. We want to determine, are they having an allergic reaction? And what are the medications that we can give to help prevent that so we can get them to the hospital? Are they having an asthma attack? What can we do to help them prevent further demise? So we're going to check for dyspnea, difficulty in breathing. Are they cyanotic? Anytime you see paradoxical or asymmetrical chest wall movement, that is a bad thing. Decreased or absent breath sounds could mean that they have a tension pneumo. And if you look and see, do they have a wound to the chest wall? Was it ailment? Was it because of a gunshot wound? And if you can find out what caused that gunshot wound, then it's going to help decide what kind of treatment they need, because it just depends on the kinds of bullets that are going to, what happens once they get into the body. Was it close distance? Was it far away? Was it a pistol? What rifle? Things that you need to ask of the family if the patient can't tell you themselves. We're going to assess them for dyspnea, cyanosis, paradoxical breathing, absent breath sounds. Where are their wounds? Are they cyanotic? Is there body parts that are cyanotic? Are they tachycardic and hypotensive? Because we know if they're hypotensive, their heart rate's going to pick up so that they can counterbalance that hypertension. So we're going to do for them what they can't do for themselves. We're going to breathe for them, either ambu bag, or if they can support their own airway, but they just need better oxygen, we can give them non-rebreather, but always monitor them to determine how good or bad their situation is. We may have to bag valve mask at with 100% O2. How many breaths per minute can they get? How many times, think about CPR, how many times are you going to breathe for patients? Every 5 to 6 seconds. Don't want to breathe any faster than that, because that's going to cause them to blow off too much CO2, which is then causing vasoconstriction. They may do a needle decompression if there is a tension pneumothorax, intubate as soon as possible, and again, try to find out what caused the injury in the first place. Circulation. If you saw that in a patient, would that scare you? Yes, you should be scared. That is not anything that you want to. So we're going to check their pulses. We're going to check their central pulses, which are, where are your central pulses? Carotid, apical, femoral. We are also going to then compare them with their peripheral. Because if they are weaker in the periphery than they are in the central circulation, then that could be what is their body doing? That process. Shunting. They're vasoconstricting to preserve the core. And what organs are the most key as far as blood and oxygen? Heart and your brain, which also auto-regulate. So as long as their systolic blood pressure is between 50 and 150, then we have auto-regulation for the brain and for the. Once it gets out of those parameters, then they're not doing very well. So we want to assess the quality and rate of the pulses. We also want to check them for color, temperature, and moisture. What's the color of their skin? Is it uniform? Are they starting to show purpura like that? Is it marching up their extremities? We're going to look for signs of shock. Are they mentally cognizant? Can they answer your questions? Do they keep asking you the same question over and over again, which could be a symptom of a head trauma? And again, we're going to check for that delayed cap refill. What can cause cap refill delay besides lack of circulation, lack of blood? Probably what a lot of you are experiencing in here. Temperature. They're cold, going to shunt. And that can cause delayed capillary refill. So we're going to get 2 large bore IVs. Do not start at 20 and do not start it in the hand. AC at least. And you want to get the biggest IVs you can. Why? You might be giving crystalloids at rapid rate, and the bigger IV you have, the more successful you're going to and being able to resuscitate them. So we could give lactated ringers or normal saline. We're give saline because if they need blood, that is compatible with that. Lactated ringers is not. Plus, what is one thing that what is one lab that we're always lactate? Again, we can give blood products, O negative for emergency. Then we're going to go on to disability. We're going to check pupils. We're also going to do a Glasgow Coma scale, which we'll talk about on the next slide. But the pupils, we want to look to see if they're constricted or dilated. So if they're constricted, again, it could be due to they're bored with what's happening. They're not sure about what they're doing. Their mind is not working very hard. They're disgusted by what they see. They don't recognize anything. Their mind is relatively inactive now, probably due to endpoint. If they're dilated, it could be a very dark room. They're interested in what's happening. They're thinking hard about something. They have confidence in the action, in their action to believe and belief. They're attracted to whatever is in the room. They have seen or heard this before, and they're thinking about something stimulating. So there's a lot of different reasons, or they could have a head bleed, head damage. So we need to look at their whole presentation, not just what their pupils are doing. With Glasgow, what's the best score? 15. Less than 8, what are we going to do? Intubate. If they're 3, they're pretty much dead. So we're looking at eye-opening. What is your best? Is it spontaneous? Is it to speech? Is it to pain? Or is there no response? Best verbal, best motor. Your patient did this. What? This. Cerebral. This. This is decorticate because it's the best. Not as bad as the cerebral. Just because they decerebrate doesn't mean they will always decerebrate. That means once that inflammation in the brain has resolved, then they may not be postural. Did you guys cover DAI in neuro? Diagonal injury? Basically where axons are torn. I think their chance of survivability. That is the brain injury. We had a patient on 34 that walked. Diagnosis. He's in some textbook somewhere. All right. We're going to expose them. We're going to look for injuries. And then we are going to make sure that we cover them and don't want them to cold stress. Don't remove impaled objects. Prevent heat loss with warm fluids, oxygen, warm rooms, have lights that also generate heat. All of these things are so they don't cold stress. So can you see what that guy has sticking out of his arm? It's actually a pen, but we had a guy who came to the emergency department and he was triage, and he had shot his middle finger with a nail gun. It was just like a Halloween thing, and everybody wanted to come and see it because there was actually they cauterized it back to bleeding, but he finally asked me if I would get him because he was tired. But it was something excited about it. That's kind of what we do. But think of that when you have a patient that comes in with such an injury, because he looks a little disgusted that they were even taking his picture. And then we're going to facilitate adjuncts and family. So we're going to do a full set of vitals. That is also the F. Want your blood pressure, and it needs to be on both arms. Heart rate, respirs, O2 sat, and temperature. And again, we talked about family presence. Only if there's somebody dedicated to the family that unfortunately, a lot of times they will ask the resuscitation team if they're comfortable with it. But there's lots of benefits for patients, family being in the room with them, and they also have to have somebody in there with them explaining everything. They can provide comfort, advocate, determine whether the code should end sooner or later. They can also calm the patient down. There are benefits to it, but again, the family has to want to be there. Cannot force them. Okay, let's take a break. It's 10:16. Let's give 15 minutes. I thought it was actually maybe. I do. Like, at the college. I could actually. I can bring him in. I do not think it is. I mean, you still have joined. So that, join your day. I've got some of that. In this one? The red and white. Oh, you mean The, like the jumpstart?
I don't know. I just know it's the.
I could, Amy. Okay. I just pull them up.
Stop, stop, this one is.
Okay.
I was supposed to. Oh, it's the issue.
Also. Just. That should be. This is the only.
I tried to override it.
know that, I know that. Okay, you're welcome. Okay, let's get started. Again. Remember your Gs, your resuscitative adjuncts, which we talked about originally. It's your labs, it's your monitor, your NG or OG, oxygenation and ventilation, and pain management, which could be pharmacological and non-pharmacological. Why would we never put an NG in a patient? Nasogastric tube, basal or skull fracture, and probably facial as well. Because if they have a basal or skull fracture and third and NG, you can actually be suctioning brain. So that's why we're going to do an OG. Okay? So pain, you want to find out what kind of pain they're having. What can we do to take it away? So you could use calming words, you can dull light, blankets, anything to help them feel more comfortable. And whatever you do, remember, if it's, you assess and you determine there's a problem, if you try to fix it, you have to reassess it. Same thing that we're going to do with either drugs, pharmacological, or. And what are we going to continue to assess our patients who come in, whatever. Remember VIP. EIP is a reassess vitals. You're going to reassess your inner, reassess their pain. Because comforting is, or comfort measures are very important to the patients. They're probably very scared, so we want to do what we can to put them in a good place. Head to toe assessment and history. Again, the history can be gathered from family members, from charts, from pre-hospital, or the patients themselves. And then you want to also determine if they have a chronic illness, what they have done in the past to take care of it, what's been successful, what hasn't worked. So we always want to be looking to see what we can do to help them. And then you're going to do that head to toe assessment. When you are doing an assessment, you want to use butterfly fingers. Okay? So you're palpating the head. And why do you want to use butterfly fingers? Because if they have the brain go into a drop off or a body spot, kind of takes your breath away. So you want to be very light. Then you want to look at the face. You want to make sure their bones are intact. Not why aren't they? Can have certain types of fractures called the. That's anything but just parts of the being loose all the way. Feel that you may not get because of fracture, so you're going to bring that back to what was the mechanism of. So you're going to do the head, the neck. Can you actually take the yes. What you're going to do is ask for assistance, ask them to take the C-collar off, and they are maintaining stability, and you're going to look for tracheal deviation for drop. Find itself. Get back on. Talking to your patient, if they're conscious and awake and alert and talking, then you're going to determine that that's not something that's going to be compromised. You're going to look at the chest. You're going to look for rise and fall, aspiration. You're going to look for intactness. Are there any broken bones? They have a flail chest segment, remember, from our weeks past. What is that flail segment? There are more bones that are session. So you're going to see when they inhale, what's going to happen to that flail segment. In. They exhale, it's going to go out. What's the biggest thing that they complain of? How painful it is. Because remember, we have those blood vessels, but we also have nerves that go in and out. So we're going to ask them to split. They put tape over that flail segment. Yes, just not circumference. Don't want to compromise them so that they're not going to take deep breaths. So it's segment itself, or you could just have them themselves. You're also going to look at the abdomen, see if it's round, see if there are any injuries there. And when you're at the chest, you're going to listen to heart sounds, you're going to listen to breath sounds. And what I like to do too is go right to the abdomen. We've got our stethoscopes, and you can listen to bowel sounds in 4 quadrants. After that, you could also ask them if they're having pain in their abdomen, and that's when you're going to go to the side that is not injured first. Because if you go to the side that's injured, cause a lot more problems for them. Okay? You're also going to look at the pelvis. Is it intact? We used to do a pop, but I didn't, but. So you're going to squeeze the pelvis, push down, and then on the symphysis. If pelvis is not intact, do not. You're also, while you're down there, you're going to look at the perineum. You're going to look for blood at the meatus. See blood at the meatus, what are you not going to do? Not going to cap them. You're going to get somebody in there who can take care of that. It's not us. What if they have a high riding prostate? That could be due, again, is something out of our expertise. And make a note of it so that we can get additional help. Then we are going to do the extremities. Everybody does extremities differently. I've seen nurses. I personally like to start far away, so I'm going to check capillary refill. I'm going to check sensation in your toe, and also the pedal. And I like to go on top. So I'll do that on each of the extremities. Up to my hands, up to my shoulders, make sure that they're in. If they are broken, we can. Again, after you do any of those interventions, have to make sure that it did good. Okay? And once they get splinted, elevated, and iced, they may be a lot more comfortable. And it's the time that you're also going to be able to assess their pain. Reassess it after you have initially. And there again, the inspect posterior surfaces. At this point, ENA is not supposed us to check their posterior. They are clear. What they're doing is they are 8 people to raise the patient up so that exercise. How many times have you seen a patient, a trauma patient who comes? Probably not. So, those are just some things to think about, but we want to make sure their spine is clear. Take them off. When do we check rectal tone? Rectal tone. You could do it with the abdominal check. Could do it as you're checking the perineum. Log roll them, that would be a good time too. If that does happen, and why would we check rectal tone? It helps us know if their spinal cord is in. Because if it's loosey-goosey, then that means that they may have a spinal. But make sure if you are in that situation that you want to check rectal tone, make sure you tell your patient. As I was in a situation where the patient did not tell the patient that he was going to check his rectal. This patient was, I don't know who, staff or the patient, check his finger. Thinking about it, probably I'll clench. Just think about that, because that's what's going to happen. Clench, your spinal cord is a good thing. And I hope you all never have to have that. So when we take a history, it helps us. It helps us know where they've been and where we can get them as far as differential diagnoses. Because very rarely do our patients come in with just one diagnosis. They can have a history of a lot of different things. We also need to know if they've used treatments in the past and they did or did not work. Because that will what we want to do first and what can be done or not done at all. We want to evaluate the change in the condition. Technology is wonderful. Are you guys hearing echoing again? Maybe it's just my brain. Okay. You always want to evaluate. Yes. Always evaluate the impact processes, because again, it might be an underlying disease process that caused the motor vehicle crash. So we want to make sure that we evaluate and not just for the reason they came in. Another way that we can collect the history is a sample. What symptoms do they? Do they have any allergies? And if so, what kind of treatments do they have for them? What's their medication history? What do you want to know as far as medication? They're taking, last time they took them, are they taking prescription meds? Are they taking counter drugs? Are they taking vitamins? Would they be counterbalancing or causing more? What are some drugs that could protect? What are some herbs? What do ginger, ginkgo, garlic, vitamin E, what do they all have in common? That can have, they prolong bleeding. So if they're on an anticoagulant and then they take those as well, then why do we take ginseng? Energy. Ginkgo. It actually causes dilation. It create a blood supply to those organs. Ginger. For nausea. Good for digestion. It also vitamin E is air teeth. Past medical history. A lot of people think, I'm in here for this, why do you want to know? I have to tell them how just why they at that moment. And what was their last meal? Taken output. Which you may not think that it could, they're suffering from severe things that you need to know. What were the events that led up to it? Might have been really upset and just got in a car and drove crazy. So all of that information, they may not think that that's what's going to picture. And do they need some psych help as well? Talked about that one. As far as your secondary survey, and if you're looking at your head, neck, and face, you want to look at that general appearance or their skin temperature and their color. Do they have a deconjugated gaze? Could mean a head injury. Do they have battle signs or raccoon eyes? Both of those symptoms probably not. What are those raccoon eyes or the black circle battle signs are. That is a. Basilar skull fracture. Do they have anything coming out of their nose or their ears? What do you think that is? Cerebrospinal fluid. How do we know it's CSF? Halo. Also, what else? Glucose. So those of you who, cell district, gonna act like they take and dip it and then taste it, but they. That. Is their airway open? Do they have sonorous respiration? Are they gasping for breath? Do they have guppy breathing? These are all things that we need to check when we're doing that head, neck, and face. And is their trachea deviated or is it centrally located? Do they have paradoxical chest movements? Never, ever a good sign. Do they have a large sucking chest wound? We're going to palpate and auscultate. We don't want to cause more sounds than were there initially. If they have a pneumothorax, is it open? Do they have rib fractures? Do they have flail segments? Do they have pulmonary contusions, which would mean they have a lot of problems with their breathing? Do they have a blunt cardiac injury? And again, that all depends on the mechanism of injury. That's why it's so very important to talk to pre-hospital. They can paint the. And we're also going to get a chest x-ray and indicate. What kind of dressing are we going to put over, let's say they poke a stick in. And then they pull it out. What kind of dressing are we going to? Two-sided or three-sided? And do we do a four-sided dressing? And they have a chest tube. And if it is a four-sided and they start to show signs of attention pneumo, make it three-sided. We want to monitor their abdomen and their flanks frequently, especially for blunt trauma, penetrating trauma, and trying to inspect, auscultate, percuss, and palpate at the very end. If we have an abdominal injury, we're going to do a FAST, which is just abdominal sonography of just to do a DPL, which is diagnostic peritoneal lavage. That was basically taking a spinal needle, going to either side of the umbilicus, injecting fluid into the abdominal cavity, and then aspirate. You aspirated fecal products, what has they have perforated their bowel, they are going to not even passing go. Don't do DPLs anymore. If it's retro. So again, we're going to gently palpate that pelvis. We're not going to rock them. We may do they may have a pelvic fracture. Then we're going to have problems with hypovolemia and fluid loss. So we want them to be x-rayed as quickly as possible. Going to inspect the genitalia and ask them if they are able to breathe or if they're having difficulty. And then again, the rectal exam by a healthcare provider after they are told it's going to happen. Your extremities, are they tender? Are they having crepitus or are they swollen? By ice packs, we can hurt. Just make sure that we don't put too much ice on them that we're going to drop their body temperature. If that extremity is pulseless, they are going to surgery immediately, or potentially they have compartment syndrome, and it's a treatment. That Sciatomy. Dark red part. And that can happen from either compromised muscles, or it could happen because there is too much fluid. Remember, we have 38 compartments in our upper and lower body. Any place you have muscles, there's compartments. And the last thing we're going to do, again, is that secondary survey is the posterior surfaces. We want to make sure that they're clear. Fine. Rectal tone, we want to support them manually and with stabilization devices. We're going to look for ecchymoses. We're going to treat them if possible. If you have a patient that doesn't have a spinal cord, to take them there and they can get off the board. When we log roll them, where are all the people? Because we need to have 3 or 4, where do you need to? We do the log roll with. Okay, let's have 4 people come up. 5. I'll start naming names. Actually, it's warmer. So it's all about not making the situation worse than it was prior to. Always, 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 that's one of the last things you're gonna do, evaluate whether they need tetanus. What would determine if somebody needed a tetanus shot? And skin wounds. Okay, what if they just got one last week? Give it again. Yes, unless they're allergic to it. We want to monitor them continuously. Always evaluate their reaction to our interventions. And if we need to put in a catheter, NG, then we will do that. But you need to evaluate the need for it as well as if if the patient can handle it. So we always want to think about some of the testing that we're going to do with the patients as well. Do we need to send them to speak? Do we need to want to make it as easy for them as we can to determine what is going to, they need to go to, going to go to. And we also have to determine, do they need to go to another facility? Us, we're a level 1 trauma center. So we're pretty much here, we got it. What makes the difference between a level 1 and a level? Kind of staffing. 24/7. So they could do surgery immediately unless that surgical suites are all busy. Whereas, two, they have so many hours to get those people in to do this. If they're just a certain type of patient, have the services for that, then they would transfer it to us as a level 1. So what are we going to do with the patient who has a cardiac arrest? We're going to do our ABCs, airway, breathing, circulation. We're going to determine, do they need chest compressions? Can we do chest compressions on somebody who has a pulse? Is it going to hurt them? That pulse appropriately, then we have to do CPR. Their brain is not being perfumed. We want to, if they are in a lethal dysrhythmia, we want to deplete as quickly as possible. What would be a lethal dysrhythmia? Tach, AFib, systole, fail. So we cannot, what does defibrillation do? It stops a bad rhythm. Yes, a systole is a bad rhythm, but there's no rhythm at all. So if we feel that it's a systole, we're going to check it in 2 leads. See if it's the same thing, if it's flat. If it's totally flat, then they're probably not. Something's wrong with them. So check 2 leads, and we only defibrillate AFib, ATAC, and multiform ATAC, which is we also, besides the chest compression and rapid defibrillation, we're going to think about therapeutic hypothermia. Why would we do therapeutic hypothermia? Okay. How long are they going to be on therapeutic hypothermia? 24 hours. And what is the termination of putting them on? Steve Ross is turn of spontaneous circulation. Right. But they're unconscious. You don't want to make somebody cold they are awake and alert. That is not a good thing to do. There's three different phases. Induction, which would normally start in the emergency department, maintenance, and rewarming. And again, they're only going to be in that phase for 24 hours. Normally, we're going to get a temperature of 89.6 to 93.2, which would be 32 to 34 degrees Celsius. But they've also had really good outcomes with 36 degrees Celsius. Think about somebody that you are cooling. What are you going to do to make it successful for them? You're going to breathe for them, so they're going to be intubated. They have to have invasive monitoring. And with the intubation, of course, you're going to have mechanical ventilation and continuous assessment. So we can start in the emergency department, but they're going to go to ICU. We can not only do this for hearts, but we can also do it for brains, like a little helmet that will keep or make their brain cold. What's this? That's our Lucas. What does it do? CPR. Seen Lucas in action? Yeah. It's aggressive. You'll notice it doesn't look like it's that big and obtrusive, and they're not really that big. Where do you think they were? Or for people. So if they're really tiny, Lucas won't work. They're very large. How long are you going to do CPR? If you 2 minutes. Have you guys done CPR for more than? It's exhausting. Lucas can help to alleviate if you don't have staffing, but one of the main reasons that they sold Lucas as being such a wonderful machine is that you don't have to have staff. You still have to make sure that it's hitting where, because its predecessor was called, basically look, and it would actually pressing that chest. There had to be a nurse assigned to it to make sure. All right, so we have a 32-year-old who arrives in the ED via paramedics. Neighbor found him lying on the rocks in the rock garden. He had fallen off the roof while fixing the shingles on his house. Always have a family member when you're going to be on the roof. His femur is protruding through the skin. What kind of fracture is that? Open, good. The paramedics arrived and he was found in a large pool of blood. What kind of hypovolemia is that? Absolute, very good. He's unresponsive. His blood pressure is 60/42 and his heart rate is 168. Does that make sense? Yeah, because he's hypotensive, so he's tachycardic to make sure that he has cardiac output. So what kinds of injuries do you think he's got? His neck might be broken. Yeah, it could. Yep, he's got a femur fracture. I don't like this machine. All right. So what potential life-threatening injuries could he have? Head injury, abdominal trauma, internal bleeding, and he's got that open femur fracture. What's our priority of care? ABCs, airway, breathing, circulation. What are we going to do for him? Intubate. And if we're going to intubate him, then we're going to breathe for him. We're going to ventilate him. Does he need fluids? Yes, lots of them and warmed. And we want to potentially type and cross him for blood. Are there any services that we would initiate? See if family is there, contact family, but get them to the hospital for treatments as quickly as possible. And what are some other alternative things that we could think about? Having all the services available so that if we need to deal with, family comes in and to give that way, and to just monitor him and everything we do, we assess and reassess. As far as a death in the emergency department, we want to make sure that we anticipate our own reactions and feelings. Is it going to be hard for us because they look like a relative, like our neighbor? And it's okay to ask your friends to step in and take over. Do not ever feel that you can't have that option, because we're all there to work together to make our team stronger. Caregivers can grieve as well as the family members. Allow family members to be there with them for a period of time. Can help them get the people they need to talk to as far as chaplains, mortuary, or possibly if they're going to be an organ donor. And that's something that has been in the hands of nurses, but it's lately been the team that has come in and they are procuring. Because certain ones have to be taken right away, others, we can have a little bit of time. We also want to give the family privacy and get whatever they want. We may need to contact the medical examiner or the coroner. We will do autopsies with family request if they were admitted and been in the hospital less than 24 hours, and if we suspect that there was trauma or violence, like if they fell out of bed and then had a bad outcome. With organ donation, they're going to screen the donors, counsel the family, form consent, and then take the organs that the family consents to. Because they can determine which organs can be donated and which can't. Many people have said this is the first part of grieving. Got very well that the organs go else and can. You guys good to go? It's only 20 after 11. Hearing yes, then. All right, so we're starting to get warmer weather now. So what kinds of things can be happening? What is this in? Yeah. Sprained ankle, right. What are we gonna do for that? Bait it, rest it, ice it, press it. Do we ever apply heat to it? That. After what? 3 days. Every 20 minutes, ice for 20 minutes, at least minimum 4 times a day, if not more. If you would apply heat, that would only make it swell more. We had a girl that came into the emergency department who sprained her ankle, and her grandmother talked her into soaking it in Epsom, which is very hot water. And it ankle just swelled so big that she actually had to go to therapy. And it still will never rise. Always ice. It's ice. Be due to activities or environmental injuries, can activities, exposure to the weather, not get cover, or attacks from animals or humans. So we're going to differentiate between the different types of heat-related emergencies. Heat stress occurs when our thermoregulatory system is not working appropriately, and that's because of the. Why is humidity such a danger? What happens when it's extreme? Would you rather it to be dry heat or wet heat? Dry. What does high humidity not allow you to do? Wet. So what happens is if you're out exercising and it's the pressure on the outside of your body is more than the pressure on the inside, so your pores will not open, which allows body temperatures to. So who do you think are people that are at the most risk? Elderly, yep. People who have chronic diseases. Sometimes it's the elderly. Sometimes if their clothing does not allow for sweat, if they're not used to it. Several years ago, we had, and in July, so it was very hot. What is the average temperature? Probably between 40 and 60, yeah. So, it's moderately, it's moist, but it's also cool. They come over, they're in wool, marching uniform, if they're in. Had at least 20. They just weren't. So what do you do for them? Bring them into places, would put ice on them, feed their pits, groins, side of their elbows, sometimes in their wrists, on top of their head, any place where you would most of them, it wasn't any time at all. They were about an hour and a half to get body temperature down. So, but none of them had any. Sometimes our clothing will not allow us to perspire. So when you're going to be exercising in the heat, that you have wicking clothing and that you are sweating. And if you're sick, don't go out and exercise in the heat. That's never a good thing. So the people that are most prone to heat problems are infants and older people. If the environmental temperature is high, if the humidity is high. Pre-existing illnesses such as cardiac, cystic fibrosis, dehydration, diabetes mellitus, as well as diabetes insipidus, because they tend to lose a lot of fluid, obesity, previous stroke, so that their brain is not able to interpret how hot it really is. Or if they also have skin disorders, like if they have a lot of burns and have scar tissue, which then don't have the pores that they had previous to the burn. People who are taking anticholinergics and histamines, because they're probably dry, anti-Parkinson drugs, beta blockers, diuretics, benzodiazepines, alcohol, amphetamines, meth. Biggest problem though is they don't have the ability to acclimate. They haven't been out in the temperatures and their body's not used to it. Physical exertion, especially in hot weather, prolonged exposure in extreme temperatures. If they had a head injury, they may not be able to comprehend what's actually going on, or if they have a spinal cord injury. If they're dehydrated, they definitely should not go out and exercise in the heat, or if they're impaired due to drugs or alcohol. Heat cramps. Going to differentiate between heat cramps and some of the more severe ones. Heat cramps occur in large muscle groups. They're fatigued by heavy work. So they could be brief and intense. They will occur after the exercise is done, so after they're resting. And you can see this in healthy individuals as well. They're the ones that are probably going to be working outside in the heat. We can also see it in acclimated athletes with inadequate fluid intake. What comes to mind when you think of are suffering from heat cramps? How about when they have football practice in summer? Hot, and they're probably not hydrated appropriately. So what are we going to do for them? Heat cramps can be relieved once they get out of that situation. They need to rest. Okay? So we can elevate, gentle massage, and they can also take analgesia. They need to avoid strenuous activities for the next 12 hours and emphasize salt replacement in the food. I know that there was one football that had his players drink pickled high salt content. And there were other medications that some individuals were given that we're not doing anymore. But remember, with heat cramps, they have them, it's not increase the temperature, they will resolve one. What you have to consider, though, is if we have problems that are worse, so heat cramps can come and go, but then you can also have problems that go beyond that, and that would be your heat exhaustion. That's prolonged exposure to heat over hours or days. So they're going to have fatigue. They could also have nausea and vomiting, extreme thirst, feelings of anxiety. So you can see there's a huge difference now between exhaustion and heat cramps. Cramps are muscular. This is affecting more of their body. Because you could potentially see tachycardia, dilated pupils, mild to moderate confusion. They could be ashen due to the decreased perfusion, and they're going to sweat and sweat and sweat. They can have hypotension and mild to severe temperature elevation, 99.6 to 105, and that's primarily due to the dehydration. But because it's not an infection, with Tylenol or ibuprofen, no. This is a worst case, this is worse than heat cramps. Heat cramps you can take anti-inflammatory. Heat exhaustion you cannot because it's not due to an infection. So for heat exhaustion, we're going to put the patient in a cool area and remove their constricted clothing. We're going to monitor their ABCs. Everything we do, we're going to assess them afterwards. We're going to start an IV with saline and correlate the drip according to their vitals. We could also put a moist sheet over them to decrease their core temperature. And they actually may have to be admitted if they're older, chronically ill, or they don't improve 3 to 4 hours. And that's pushing the button. 3 to 4 hours is kind of long for an individual who's very hot. If we don't aggressively treat our patients, they can go into heat stroke, which is the most serious form of heat stress. And that's when their hypothalamic, the thermoregulatory system does not work anymore. This is definitely a medical emergency because of the vasodilation, the increased sweating and respiratory rate, depletes the fluids and electrolytes, and especially sodium. And we know that when people lose sodium, what is a symptom that we can pretty much assess? Taking care of people who have decreased that you can recognize. Change in level of consciousness and confusion. So we want to get them the lights that they need. With a heat stroke, their sweat glands are no longer functioning. Their core temperature will increase within 10 to 15 minutes. It can go up to greater than 105.8 Fahrenheit. So again, they're going to have a mental status change. Absence of perspiration, which only makes their heat go higher. And they're actually going to go into circulatory collapse. So they'll have hot, dry, ashen skin, and it is actually hot to the touch. And a lot of neurological symptoms. Death is imminent if we don't bring their temperature down. And again, their prognosis is related to their age, any other underlying diseases, and the length of exposure. What are some ways that we can cool them down? Fluids, as well as maybe a bear hugger or an Arctic Circle, which basically will them down under condition. We don't want to cool down too rapidly because then that causes more problems with the brain. We want to stabilize their ABCs, decrease their core temperature, move their clothing. And again, if it's a chronic disease, we want to cool them down, but not as fast as we would somebody who not having underlying disease processes. We can cover them with wet sheets and spray with lukewarm water, put them in front of a fan, immerse them in cold water bath, put ice packs to them, as we discussed earlier. And if they are having a really hard time bringing their temperature down, we can do peritoneal or rectal lavage with iced fluid and monitor them closely. We want to control the shivering. Why do we want to control shivering? Increases your body temperature. We want to control it. And that will complicate your cooling efforts. You could give drugs to drop their temperatures. Antipyretics are not effective because, again, this is not related to an infection. We want to monitor them for organ shutdown with rhabdomyolysis, and that's when your skeletal muscle is breaking down and you have all these impurities then in your blood. They can also get myoglobinuria, so your kidneys are going to be at risk for injury, as well as with the rhabdo, and they can actually go into DIC. So they're going to totally get rid of all of their clotting factors. So the big thing is to teach them how to prevent it and not do it again. All right, it's 11:30. Do you want to keep going or do you want to break for lunch? Break for lunch? Okay. 45 or an hour? 45. You're not in charge, miss. I'm going to give you a special. Okay, so 12:15.